A pleasant day, everyone. This will be the second set of lecture for the session on communicable disease. And I will talk about the epidemiology of tuberculosis. For the objective, at the end of the session, the student should be able to know the global and Philippine burden of TB and explain the policies and guidelines stated in the National TB Program Manual of Operating Procedures. You can view the Manual of Operating Procedures in Canvas. So we uploaded a PDF of the Manual of Operating Procedures for TB. For the Global TB Report of 2023 from the World Health Organization, the overarching findings are that major global recovery in the number of people being newly diagnosed with TB in 2022 after 2 years of COVID-related disruptions. So during the COVID pandemic, there was a decrease in the number of cases of reported cases of TB. But right now, we are now recovering from that. And these have started to reverse or moderate the damaging impact of the pandemic on the number of people dying from TB and falling ill with TB. But in 2022, TB remained the second leading cause of death from infectious disease after COVID-19. And the global TB targets set for 2018 to 2022 at the first UN high-level meeting on TB were mostly missed, and the anti-TB strategy targets are off track. This is the number of cases of newly diagnosed TB. So from 2010 to 2022, as you can see from this report, there was a sudden drop of the number of incidents of TB in 2020. And this is due to the quarantine, because during the quarantine, people who have symptoms cannot go to the health center and they were not diagnosed as having TB. But right now, there was already a resurgence of the number of cases of TB, and we have recovered from the time of the pandemic. For the recovery of the number of cases, so 60% collectively of the global reduction in 2020 and 2021 was from these three countries, India, Indonesia, and the Philippines. As you can see, for the Philippines, we have increase in the number of newly diagnosed cases of TB. For the global number of deaths caused by TB, the decrease in 2022 is now reversing upward trend in 2020 and 2021. So these are the number of cases of deaths. So the number of cases of deaths are decreasing, total number of cases of death. Then in 2020, there was an increase in the number of total deaths. And this is because, again, due to the quarantine, so people are not being able to get their medicines for TB. And because of that, a lot of people died in TB. These numbers, these COVID-related disruptions resulted in about 500,000 excess number of deaths from TB during the pandemic. So again, in 2022, TB remained the second leading cause of death, second only to COVID-19. And we have an estimated 1.13 million number of TB deaths among HIV-negative people. Okay. So second only to COVID-19, which has reported 1.24 million cause of death, and HIV/AIDS death is 0.63 million. In total, 8 countries out of the 30 high-burden countries accounts for 68% of the global cases of TB in 2022, and the Philippines is included in these 8 countries. 10 countries account for 71% of the global gap between TB incidents and reported cases. This means that there are a lot of patients who have TB, but they are not diagnosed and they do not know that they have TB. And again, Philippines is included in this one. So we have the size of gap for the Philippines is more than 500,000. For the Philippine burden of TB, we are 4th of the 30 high burden countries in terms of TB incidents. We constitute 70% of the global incidence of TB. We are number 17 of the 30 high burden countries in terms of TB HIV incidence, and second of 30 high burden countries in terms of MDR-TB, or moderately drug resistant tuberculosis. We constitute 7.5% of the total of the global cases, And we are only second to India, which constitutes 27% of the global cases. TB is still the number 9 leading cause of morbidity in 2022 and the 8th leading cause of death in 2023. So TB is one of the only communicable disease as being included in the top 10 mortality causes in the Philippines. For the NTB strategy from 2016 to 2035, these are the targets, and we want to target 95% reduction in TB deaths and 90% reduction in TB incidence rate. For the natural history of TB, the agent is Mycobacterium tuberculosis. Reservoir humans. Mode of transmission is airborne droplets or direct transmission, and the incubation period is 2 to 10 weeks. The period of communicability is as long as viable tubercle bacilli are being discharged in the sputum. And this is the reason why in the past, we only treat those who are sputum positive because they are the ones that are communicable. Okay. And for the specimen, we still use the sputum for gene expert. Now we talk about the 6th edition of the Manual of Procedures for the TB Control Program, which was published in 2020. They are now cooking up the 7th edition of the Manual of Procedure, but as long as as it is still not yet published, then we will still continue to use the 6th edition. What is new in the 6th edition? The emphasis is now on patient-centered care for the 6th edition of the Manual of Operation. And it already included guidelines for MDR-TB. Before, we have a separate manual for MDR-TB. Now, for the 6th edition, they have combined the MDR-TB and the non-drug resistant TB. Okay. And they also included guidelines on preventive treatment. Before, we do not allow preventive treatment of TB because we are up to now we are still contemplating that preventive treatment may lead to MDR-TB, but the latest and even the 7th edition will still have guidelines for preventive treatment of TB. For the screening, we had the change of the screening procedures from passive case finding before. When we say passive case finding, it means that we're only waiting in the health center for people who have symptoms of TB to come to the health center for diagnosis. But now we have intensified case finding in the health facilities. When you say intensified case finding, it means that the close contacts and the contacts of those with TB are now being asked to go to the health center for diagnosis of TB also. We also have active case finding in targeted communities, workplace, and congregate settings. These targeted communities included industries, workplaces, and TB in prison. Okay. They are also now implementing enhanced case finding. These are systematic screening in the community using symptoms screening such as house calls, visit by the community workers. So these are the TB teams in the community. For the intensified case finding, we ask the patient if they have the signs and symptoms for TB. If they have the signs and symptoms for TB, even if it's only just one signs or symptoms of TB, then they are already classified as having presumptive TB, and gene expert will now be requested. If they do not have any signs, but they are the close contacts of those who have TB, then a chest X-ray will be asked. If the chest X-ray is suggestive of TB, then again, gene expert will be requested. If not, then the case finding ends there. For active case finding, again, this is for the workplace or in prison. We screen everyone using chest X-ray. And if the chest X-ray is suggestive of TB, then we request for gene expert. If not, then that is the end of the evaluation. For the gene expert, this is how we interpret our findings for the gene expert. If the findings is letter T, then it means that the patient has TB, but there's no drug resistance. If the finding is RR, it means that the patient has TB and he is resistant to rifampicin. If the notation is TI, then it means that the patient has TB, but it is indeterminate whether they have resistance or not. For these types of cases, then we have to repeat the gene expert. Findings of N means that there's no TB detected, the patient is clear, and findings of I means that the specimen is not a valid specimen, and most probably the subject gave saliva instead of sputum. For the sputum microscopy or TB lump interpretation, we need to have at least one sputum smear positive to diagnose the patient as having a positive sputum exam. And for a negative sputum exam, we want both sputum smears to be negative. So we only ask for 2 sputum smears now. In the past, we asked for 3 sputum smears per patient. For the diagnosis of TB in children, if they are classified as having presumptive TB, then we classify them as having pulmonary TB or extrapulmonary TB. For those who have extrapulmonary TB, then we try to get a specimen for gene expert. And if the gene expert is positive, then we confirm that the patient has TB. But if the patient cannot expectorate or if the samples cannot be collected for extrapulmonary TB, then we refer the patient for further investigations to pulmonologists. Okay. If it's presumptive TB, then we ask for expectorate sputum or gastric lavage sample if available. Then again, do the gene expert. If the patient is negative, then or patient cannot expectorate, then we ask for a chest X-ray. If the X-ray is strongly suggestive of TB, then we classify them as having clinically diagnosed TB. If the gene expert is positive, then we classify them as having bacteriologically confirmed TB. Okay. I'm sorry. For the TB disease registration, we classify the patient as being a new case of TB if the patient has never had any treatment for TB, or if the patient has TB treatment but it is less than 1 month. Okay, so preventive treatment for TB is not classified as treatment for TB. The patient is classified as a retreatment case if the patient has been previously treated for at least for more than 1 month in the past. For the retreatment cases, we classify them as relapse if the patient was previously treated for TB and declared cured or treatment completed, but again has a positive findings for TB. And they are considered as treatment after failure if they failed the seroconversion failed at the end of the treatment, meaning the patient is still positive for sputum smear at 5 months of treatment. Okay. And the patient is classified as treatment after loss to follow-up. If the patient was lost, if the patient did not complete the treatment, and the patient had at least 2 months treatment during the previous course. Okay. We classify patient as having previous treatment at outcome unknown if we cannot find any records of the results of the TB treatment of the patient. And for any other categories or classification that is not listed here, then we classify them as patients with a known previous TB treatment history. So to further explain this, I'm going to give you a case. For the exams, you will see a lot of these cases for the exams. Okay. So for the case, we have Densho who was diagnosed with PTB last January. When he consulted because of persistent cough, he was started on standard treatment regimen, which he took only for 2 weeks. He discontinued using the drugs because he noticed a change in the color of his urine, and he has stopped taking them since the color changed in the urine. And right now, he went again to the health center, and he was again tested positive for TB, which is not surprising because he discontinued his treatment. So what will now be his category? A, B, C, D, or E? Okay. If your answer is new smear positive, then you are correct. Okay. Why new smear positive? Because if you would look at the duration of treatment, this duration of treatment is less than 1 month. So if it is less than 1 month, even if the patient previously retreated for TB, then he's still classified as new smear positive. How about drug-resistant TB? So we classified the patient as having monoresistant if he's resistant to only one drug. We classify them as having polyresistance if they are resistant to at least 2 drugs, but those drugs are neither rifampicin or isoniazid. Okay. And we classify them as having multi-drug resistance if their resistance is at 2 isoniazid and rifampicin. Okay. And we classify them as having extensively drug-resistant TB if they are resistant to any fluoroquinolone or at least one of the 3 injectable second-line drugs. So these are the drugs that we give for patients who have MDR-TB. If they are still resistant to these drugs, then the only thing that we can do for those patients is to pray. And these are the treatment regimens now for TB. So there was again another change for the treatment regimen because before we have treatment regimen 1, 1A, 1B, 2A, 2B, 3A, 3B. But now we only have two categories of treatment regimen. So one is for 6 months and the other is for 12 months. And the 12-month treatment regimen is mostly for extrapulmonary TB, while the regimen 1 is mostly for pulmonary TB. Okay. For the treatment outcome, we classify the patient as cured if there is a seroconversion of the sputum smear, meaning when he came in, the patient is positive for TB, and during the 5th month sputum smear, the patient is now negative. Okay, so with that seroconversion, we now classified him as cured. Okay. Patients who are classified as completed, these are patients who are sputum negative from the start of the treatment. Since they are negative from the start of the treatment, then they will not have any seroconversion. Okay, so they are now classified as treatment completed. And who are these people who are negative from the start? So these are people who have negative sputum smear, but have positive chest X-ray findings of TB. Okay, just like the clinically diagnosed TB for children. Okay. Patient is classified died if he died, and treatment failure is if the patient is still positive at the 5th month of treatment. Okay, so the patient started as positive, then at the 5th month of treatment, the patient is still positive. Then the patient is classified as having treatment failure, and the patient will now be tested for drug-resistant TB. And most probably, these are the MDR and XDR-TB patients. Loss to follow-up is self-explanatory, and not evaluated is also self-explanatory. And these are the treatment regimen for MDR-TB and rifampicin-resistant TB. So these are just nice to know. You do not need to memorize all of these. Okay. How about preventive treatment for TB? So these are the people that can be given preventive treatment for TB. Who are these? So these are people who have HIV, the household contacts of bacteriologically confirmed TB, children less than 5 years old who are household contacts of clinically diagnosed PTB, and close contacts of bacteriologically confirmed PTB outside of the household. These are close contacts of the subject or the patient in his workspace. Okay. And other risk groups are patients receiving dialysis, patients preparing for an organ transplant, patients initiating anti-tumor necrosis factor treatment, and patients with silicosis. And this is the TB preventive regimen treatment. So we give isoniazid daily. And this is the one currently available under the program. Okay. And for the future of TB, okay, we now have 3 new diagnostic products to detect drug-resistant TB being recommended by the WHO. There are now 29 existing clinical drug trials for the treatment of TB. And out of these 29 clinical drug trials, we have 28 new drugs for the treatment of TB in these clinical trials. There are also ongoing clinical trials for vaccine for TB. So these are my references. The WHO Global Report for TB in 2023 and the National Tuberculosis Program Manual of Procedure 6th edition. Again, the 6th edition is uploaded in your Canvas, and you can download the 6th edition of the Manual of Operations for TB from Canvas. In summary, I have discussed the global and Philippine burden of TB and the Philippine program for TB, especially the Manual of Operations for TB. If you have any questions, you can use the discussion section in Canvas for your questions. And don't forget to evaluate the lecture. Thank you very much for listening.